So AL amyloidosis obviously is a deposition disease which goes back to a plasma cell clone that has grown over time and produces light chains that tend to form amyloid. So basically it's a plasma cell disease, right? So if you want to treat the underlying disease, you need to concentrate on a plasma cell clone, and it's important to understand what the clone is composed of, right? And we know coming from myeloma therapy that there's high risk, there's low risk, and so on, and there's plenty of factors you can look at. And the same applies for amyloidosis, obviously, as well, right? Because it's a plasma cell disease. And the thing is, we've always concentrated, to see when deciding on therapy for AL amyloidosis, we were always coming from the side, well, we want to give the maximum possible therapy, which would be high-dose chemotherapy, right? Melphalan. And so usually when you're at a talk, you hear, well, the first thing to consider is this patient high-dose chemotherapy eligible? And now when you dissect the population of AL amyloidosis, not every patient is the same, obviously. So the question is, does every patient need that high-dose chemotherapy? And I think the field has, over the last years, has developed in that direction as well. But we're really still missing the prognostic factors. I mean, we know what makes good prognosis, what makes bad prognosis, but we really haven't come to a point yet where we can decide on if we should transplant a patient up front or right after induction, or if we can wait. And so we have to give some thought on that. And from myeloma therapy, again, we know that there's not only myeloma, there's also, for example, monoclonal gammopathy of unknown significance, which is basically a non-malignant plasma cell clone. That has some clinical significance in the case of amyloidosis, and nobody would transplant that, right? I've seen you've talked to Ms. Gabriel over the last days, yeah. She's an expert in that, and I bet she would agree that you don't transplant AL amyloidosis, or that you don't transplant AMGUS, right? So coming from that point of view, if you look at patients that have a low risk AL amyloidosis plasma cell clone, I think you can really start thinking if you should transplant those patients and have the risk of high toxicity, or if you shouldn't. But we're really still at the beginning of the whole topic to understand what plasma cell clones should be transplanted and which shouldn't. So I've seen some very interesting papers today or over the last days already at this conference that they are looking at high risk, low risk. But I can't give you an answer right now, but it's definitely something that's developed. And if we look at the guidelines, over the last years, I think we've seen there's the Mayo 2020 guideline and the ISA guideline from this year, and they all give the doctors the opportunity to wait with high-dose chemotherapy if there's a good response. And that tells you something about which direction the field is going. But you can always see if the response is good, you can wait, but maybe there's a way to tell before, if you look at the clone itself, and give a recommendation how the patient is treated.